Hello everyone, my name is Michael Natili and I'll be taking you guys through a ECMO PowerPoint here. I currently work at Emory Midtown and this is a pretty common treatment that we do for ARDS patients, mostly more EUH, but we do a little bit at EUHM as well, so I'm pretty familiar on this topic. So hope you all guys learn a little bit from this PowerPoint. So some of the learning objectives we'll be discussing today will be defining ECMO, identifying the founder of ECMO and some of its history, understanding what ECMO does and how it works, understanding the rationale and differences between VA and BV ECMO, identifying the indications and contraindications, advantages and disadvantages, side effects, the components, initial settings, configurations, the ECMO circuit, how to troubleshoot potential complications, and how to troubleshoot them. And then lastly, to titrate and wean blood flow. So introduction to ECMO, it's known as extracorporeal membrane oxygenation. ECMO is a man-made life support system that temporarily replaces a patient's heart and lungs when they are too sick to function on their own. ECMO takes over your heart and lungs and when they are too sick, and it takes oxygen-poor blood out of your system through a vein, runs it through a ECMO device to oxygenate it, and then removes CO2 on the way out, and then it returns it through an artery for systemic circulation. As many of you know, during the COVID-19 pandemic, ECMO was widely used with patients that suffer from ARDS and pneumonia related to COVID. Titrating and weaning blood flow in ECMO involves slowly and gradually reducing flow rate until the patient is ready for decannulation. The rationale between VA and BV ECMO depends on whether the heart and lungs need to be treated or just the lungs. Adverse side effects can include bleeding, circuit to rupture, and for the circuit to form small clots or air bubbles in it. Some of the history of ECMO, it's dating back to 1882 when the bubble oxygenator was first developed to oxygenate blood. In 1916, this is a big discovery. Heparin was first discovered. This was a very important discovery for anticoagulation purposes and to counter blood clotting, as we all know. In 1929, Russia had the first reported extracorporeal perfusion of a dog. Through the 1930s and 1950s, further development of the oxygenator. In 1953, the first successful cardiopulmonary bypass. 1958, development of the first membrane oxygenator. ECMO was discovered by Robert H. Bartlett, MD. Its main purpose was to serve as a long-term bypass machine to support the lungs or heart, which was not feasible at the time with conventional bypass machines. The first successful adult case was done in 1971 by a patient with severe lung dysfunction after a motorcycle accident. And in 1975, it was also successfully treated for a baby who had severe lung injury from meconium aspiration, which led to the increased use in the pediatric population. 2009, ECMO was used worldwide in the treatment of severe lung failure during the H1N1 influenza pandemic. And then most recently, during COVID-19 for severe ARDS and pneumonia. You can see on the right the first adult patient by ECMO, and then on the bottom the first neonatal survivor. The adult was treated by Donald J. Hill using the Bramson oxygenator, and then on the bottom with baby Esperanza, the first ECMO survivor suffering from a severe meconium aspiration by Dr. J. Bartlett in 1975 and 1976. The EOLA trial was randomly assigned 249 patients with severe ARDS to receive early VV ECMO or conventional low tidal volumes and low pressure ventilation, and we compared the two. ECMO resulted in improved oxygenation over mechanical ventilation, more days free of renal failure, 46% versus 21%, and fewer patients with ischemic stroke, 0% to 5%. Study was stopped early by the Data Safety and Monitoring Board for interim results that were in favor of ECMO. And then after the final analysis, the 11% difference in actual 60-day mortality was also in favor of early ECMO, but was not significant, 35% versus 46%. So what is ECMO? ECMO is a man-made device that essentially takes over for a patient's heart and lungs and performs the duties of each organ when they no longer can function effectively. ECMO can be used for days up to weeks, mostly used in conjunction with mechanical ventilation, but it can be done without mechanical ventilation, but it's very rare. Can be used in the supine or prone positions, especially with patients with ARDS. Can be used in patients of all ages, from neonates to adults. ECMO therapy is used only when other conventional treatments have failed to resolve the underlying heart or lung disorders. And it is used as a bridge therapy. It's not a treatment, it's more of just a temporary replacement for the heart and lungs while they have time to heal. So how does ECMO work? Connecting a patient to ECMO requires surgery, obviously, in which a surgeon places plastic tubes or cannulas. After the patient is given anticoagulants to prevent blood clots, the surgeon inserts these cannulas into a patient's large arteries or veins, typically in the neck, chest, or legs. Once connected, the ECMO machine draws blood from the patient, which it then passes through cannulas and into an artificial lung that infuses the blood with oxygen and removes CO2. The ECMO machine then warms this treated blood to body temperature and pumps it back into the patient. In cases where a patient's heart cannot circulate blood on its own, a mechanical pump takes over the heart's role and pumps blood through the patient's circulatory system. So we're going to go over both types of ECMO here. We're going to start off with VA ECMO. You can see a little diagram on the left over there. Cannula being placed in the vein, going through the ECMO pump, and coming back into the patient's body to circulate blood throughout the system. So VA ECMO is used to provide both circulatory and gas exchange support. It is very similar to cardiopulmonary bypass, which was used during cardiac surgery and can be considered as long-term cardiopulmonary bypass. Provides support for the patient's heart and lungs by allowing most of a patient's blood to move through the circuit without going through the patient's hearts. This type of ECMO takes blood out of a large vein and returns it to a large artery, allowing oxygen-rich blood to circulate through the body even if the heart is too weak to pump it. 2 cannulas must be placed in either the neck or the groin, and then VA ECMO may be applied via central or peripheral cannulation. Some indications for VA ECMO: profound unresponsive shock from myocarditis, myocardial infarction, pulmonary embolism, drug overdose, cardiomyopathy, primary graft failure post-heart transplant, bridge-to-heart transplant or VAD, ventricular assisted device, post-cardiotomy, outcome often poor, and refractory cardiogenic shock. And then we have some contraindications for VA ECMO. The age being greater than 70 years old, an active malignancy, severe brain injury, previous bone marrow transplant, previous heart, lung, renal transplant greater than 30 days, AIDS-defining illness despite antiretroviral therapy, cirrhosis, end-stage renal disease on dialysis, and then some specific contraindications for VA ECMO: aortic dissection, severe aortic regurgitation, and then multi-organ failure. And then we go to VV ECMO here. This is going to be just like where it's just cannulated through veins here. Used for respiratory failure refractory to mechanical ventilation in the context of adequate cardiac function. So the heart's working just fine, it's just not the lungs. It provides gas exchange support, but it does not provide direct cardiac support. The primary aims of VV ECMO are to provide adequate gas exchange to support life and thereby facilitating a significant reduction in mechanical ventilation, reducing ventilator-associated lung injury, and allowing the best chance of lung recovery. 2 cannulas are placed into veins in spots close to or inside the heart, usually in the right atrium. With VV ECMO, the surgeon cannulating physician has an option of using a special type of cannula with 2 lumens pathways inside the tubing. This allows for blood to leave and return to the body in one place, creating the need for only one entry side instead of 2. Indications for VV ECMO. Common indications include severe pneumonia, status asthmaticus, pulmonary vasculitis, ARDS from primary lung injury with a PF ratio of less than 100, acute graft failure following lung transplant. And then some of the possible indications are pulmonary contusion or hemorrhage, bridge to lung transplantation, or secondary ARDS, pancreatitis, burns, etc. The contraindications for VV ECMO, again, 70 years old or greater, active malignancy, severe brain injury, previous bone marrow transplant, previous heart, lung, or renal transplant greater than 30 days, AIDS-defining illness despite antiretroviral therapy, cirrhosis, ESRD on dialysis, and then the specific contraindications for VV ECMO are chronic lung disease, not eligible for transplant, and profound shock with multi-organ failure. Now we have the advantages and disadvantages of ECMO. The advantages include eases the strain on the heart and lungs, allowing for these organs to heal while ECMO takes over temporarily. Allows for a bridge for doctors to find out what is wrong and to keep a patient alive during surgery. Supports the patient as the patient awaits an organ transplant, or helps infants that are born prematurely with underdeveloped heart and lungs. The disadvantages include bleeding or clotting. It can occur anywhere in the body, but most seriously in the brain. Infection. ECMO can impair the immune system, making patients more susceptible to infections such as bloodstream infections, ventilator-acquired pneumonia, and candida. Neurological problems can cause stroke and seizures. The cannula can become detached. And then the costs. ECMO is very, very costly. It's $10,000 per day. The components of ECMO. The basic components of ECMO the circuit include a blood pump, a mechanical pump, usually centrifugal, that propels the blood through the circuit. A membrane oxygenator, a membrane-based device where gas exchange occurs, removing carbon dioxide and adding oxygen to the blood. Heat exchanger maintains the blood temperature through the circuit. And then the controller. The controls sweep settings and flow settings. We have a couple settings on the controller. The sweep gas flow is the rate at which sweep gas is delivered to the ECMO circuit. Sweep gas is usually 100% oxygen. This is used in conjunction with sweep speed. Now we go to sweep speed, the speed at which sweeps gas is delivered to the ECMO circuit. Higher sweep speeds remove more CO2. Blood flow rate, the rate at which blood is pumped through the ECMO circuit, and then pump speed, the revolutions per minute of the ECMO circuit. A higher RPM generally means a higher flow rate. And then, of course, the cannulas. These are catheters inserted into the patient's veins or arteries to draw blood out and return oxygenated blood back to the body. So the initial settings of ECMO, typically we start off with a sweep gas flow of 2 to 5 liters per minute and a blood flow rate of 2 liters per minute. The initial sweep is usually set at 50 to 100% of the ECMO flow rate, usually closer to 50% as newer membrane oxygenators are more efficient. Now, if a patient is on a ventilator, the initial ventilator settings are usually like in lung protective modes, with a plateau pressure of less than or equal to 25 centimeters of water, a set tidal volume of 4 to 6 mLs per kg, a positive end expiratory pressure peak of 10, respiratory rate of 10, FiO2 at 30% on the ventilator. These are known as rest settings, while ECMO takes over for the oxygenation and CO2 removal. The mode usually is pressure control to limit ventilator injury, induced lung injury, and to manage airway pressures. The FiO2 per membrane oxygenator is 100%. Adjust the settings based on the patient's oxygen and hemodynamic needs. Increase flow if the patient has signs of hypoxemia, such as low oxygen saturation or low partial pressure of oxygen PaO2. Decrease flow if the patient is showing signs of recovery, such as improved oxygenation or cardiac function, and do not reduce the flow below 1 liter per minute, as this can increase the risk of blood clots. Troubleshooting. So at any point, something can go wrong during an ECMO circuit, and there's usually some of the common things that can go wrong. With a high free hemoglobin level, look for intravascular hemolysis, such as dark red, urine, or if the patient's on CRRT, effluent with high potassium levels. Assess the circuit for signs of malfunction, such as noisy pump head, visible access insufficiency, or high transmembrane pressure gradient. If clinical evidence or hemolysis or circuit malfunction is present, contact the ICU. If there's insufficient access, identify visible access insufficiency, which can cause hemolysis. Seek and treat for causes such as hypovolemia, bleeding, poorly sited access cannula, cardiac tamponade, excessive RPM setting, increased intra-abdominal pressure, aortic regurgitation, or pulmonary hemorrhage. Bleeding from the ECMO cannula site, fully inserting the cannula to the taper, thrombotic dressings, pressure, cessation of heparin, repair, and recannulation. Pump failure causes include head, side centrifugal pump disengagement, electrical motor failure, or battery failure. Management includes addressing the cause and reestablishing pump function or obtaining a new console. And then if something were to happen with an unintentional ECMO decannulation, bleeding from cannula insertion site, ECMO support stopping, and loss of patient's blood volume until the circuit is clamped. Now, coming off ECMO, it's a slow process. Weaning off ECMO is one of the most challenging aspects of ECMO management. It can be divided up into either VA or VV ECMO. In VA ECMO, patients need to have a MAP of greater than 70 with low vasopressor support, CVP of 8 to 12, PCWP of less than 18, adequate ABG results, adequate O2 results, and an EF greater than 25 to 30%. In case of cardiogenic shock, the underlying cause may be corrected or before weaning can begin. Weaning is started by gradually reducing the overall blood flow rate on the circuit, with reducing the flow rate by 0.5 to 1 liter per minute. Flow rate should not drop below 1 liter. If the patient shows sign of inadequate cardiac output, inadequate tissue perfusion, increasing blood lactate levels, or findings of ventricular failure, the patient should then be placed back on full support. And then for VV ECMO, the patient's respiratory function should be examined. PF ratios should be greater than 100 with an FiO2 of less than 50% and a PEEP of less than 10. Most patients on VV ECMO have a sweep gas set at 100%. As lungs oxygenation and ventilation improves, the settings on the ventilator should be first adjusted before decreasing the sweep gas percentage. ABG should be serially drawn, showing adequate oxygenation and ventilation. If the patient tolerates the weaning with tolerable ABGs and vent settings, the sweep gas can continue to be titrated. After 20 minutes after the sweep gas is turned off, the patient's O2 saturation ABG results will determine if the patient can support themselves oxygenating and ventilating. And this should be continued for 1 to 6 hours, depending on the patient. So in conclusion, ECMO is a bridge treatment that temporarily takes over for the heart and lungs to give the organs time to heal. There are 2 types of ECMO, VA and VV. Each cater to their own different clinical situations. ECMO remains an ever-evolving treatment option for patients suffering from a wide array of conditions. Studies have shown that ECMO can be an effective bridge option for patients that have ARDS, COVID-19, and from post-cardiac arrest. And then ECMO serves as a critical intervention for patients experiencing severe respiratory or cardiac failure, especially when conventional treatments have failed. Effective management and troubleshooting of ECMO circuits are essential to minimize complications and optimize patient recovery. Historical milestones in ECMO development highlight its evolution from early oxygenation models to advanced life support systems used in modern medicine. And then ECMO serves as a critical intervention for patients experiencing severe respiratory or cardiac failure, especially when conventional treatments have failed. Here's my references.